Hey y'all, hey, thanks for joining another episode of Safe Space with Shay. Today I am super excited. I have been waiting so long to get a psychiatrist on Safe Space with Shay, and I'm so happy to have him on today. Dr. Olele, he's a board certified psychiatrist. He's located in his practice is located in the greater Washington, D.C. metro area. He is the owner of Genesis Psychiatric Solutions and Genesis PMS and Wellness. Welcome, Dr. Olele. How are you?
Hey, I'm good. Thanks for having me. Thank you.
Thank you for joining me. I know, being a psychiatrist, I know you guys are in a high demand nowadays, and I know your time is valuable. So I thank you again for making time and space for me today and my audience.
No problem. I'm glad, to come on your show and talk about mental health topics because, we definitely got to talk about them.
Definitely, for sure. So I like to ask my guests, what sparked your interest to become a psychiatrist?
I've always been interested in human behavior and the way we act, even as a kid. I didn't know what it was where I was going in my life, but I enjoyed watching TV, cartoons, and I just enjoyed watching human interactions, or people watch. It was just fun to understand how people tick. When I was in college, I was a RA, and my residents on the floor would come to my room and seek advice. So I was, counseling at the time, giving some counsel without even knowing it. I was counseling them. And then it came down for me between family medicine and psychiatry, but my love for psychiatry was evident and, no regrets. And I was a psychobiology major at UCLA too. So
Nice.
It just all aligned for me.
Nice. Isn't that amazing when everything just comes together? You're kind of like, okay, I don't know what direction, and then things start to fall in place.
Yep.
It's pretty amazing. Well, I am so glad you are here because we need psychiatrists, especially men of color. In our community, there is a stigma around mental health. I do believe that that stigma is slowly but surely lifting. But today, why I have you on, because I want to talk about the mental health diagnoses that aren't often talked about, right? So we hear anxiety, we hear depression, but we don't often talk about the PTSD, the bipolar, the schizophrenic. Those are mental health diagnoses that our community has, and a lot don't see it. Even psychosis, right? These are mental health diagnoses that we don't often talk about. So I wanted to ask you, how does that, do you see that a lot in your practice, right, amongst your African-American clients?
Yeah, I do see this in practice, and even before I had my practice, I was also a medical director at some outpatient clinics, medical clinics in Washington D.C. I'm serving low-income population, and I was also serving patients in Prince George County in Maryland. So I've seen it all the way around, and I was supporting a lot of African-American patients. And so a lot of times you see people struggling with schizophrenia or even psychosis, where a person is experiencing paranoia, feeling like people are spying on them, conspiring against them. They feel like the police, FBI, CIA, people are monitoring them, or they could even feel like, they have disorganized thoughts, disorganized speech. Or another thing I do, common in practice, and most psychiatrists see this, is our patients that are saying, hey, doc, I hear voices or I see things that shouldn't be there. And so those are some of the few things that we see with a person struggling with schizophrenia. And here's the thing that a lot of people don't know. You can have major depressive disorder and you can have a psychotic feature with that. Or you can have a bipolar disorder and have a psychotic feature with that as well. So psychosis is there, and a lot of people don't know about it. They just see what they see on the TV or saying, oh yeah, that person's like talking to the wall or anything, but it's more deeper than that. We have people who you're on the bus with, who serve you food at your favorite restaurant, your favorite coffee shop, or people you may work with who may have it, but the reason why you're not noticing it is because they're medicated. And so this is very common. And I'm very happy that we could have this conversation because I really want to break down the stigmas of all types of mental illness and make it to the point where people can empathize with somebody struggling with a bipolar disorder, schizophrenia, PTSD, major depressive disorder, OCD, all of these conditions. So I'm excited for you for allowing me to be on the show. And so,
thank you. Yeah. Thank you so much. Okay, so I heard you mention too about these diagnoses, right? And how we look at more of what we see on TV or the movies, right? That's more of an extreme case. Now, you can have a bipolar or a schizophrenic or OCD or whatever. And is it like an acute, chronic, complex? Like, how is it, the classifications, right? As far as like what's manageable and what's not, I guess. If I'm saying
it's all they're all variable because there's some people that have been struggling since they're teens. There are people that get it the first time because they consumed a substance like marijuana, cocaine, or whatever substance they're consuming, and it caused them to have a psychotic break, and where they're having these symptoms of hallucination, disorganized thinking, paranoia. So it's all variable. Everybody is different. And a lot of times if somebody does have an acute situation, they might be in a situation of crisis because it's very new. And so a lot of times family members or would try to get their loved one admitted into the hospital. And that's where they come into the hospital. We help stabilize them. And then when they get stabilized in the hospital, they get what we call discharged from the hospital to their psychiatrist in an outpatient setting or a community health center that can help them with their needs. So there's different angles where somebody could get assistance and treatment.
Okay.
And the chronic patients are the ones that are, they're on med management, and they're, like I said, they're the ones who are they're just living their normal lives in society, but they're just taking medicine to control those symptoms.
Okay. And then you probably got like above that, is there like a more severe diagnosis where, okay, this person needs to be constantly monitored, maybe in an inpatient home, psychiatric home or something like that?
Yeah, what we notice is when the person's condition gets to the point where they're a threat to themselves or a threat to others, and their reality is not stable. So where the delusions have taken over, where they can't tell what's real and what is, or they may cause a threat to others and are probably harming them as well. So that's when it's really severe, or we notice that they're neglecting their basic needs like showering, eating, and things that we would view for us to function well. Or people are noticing that they're not coming to work, they're not performing well, they're making now more mistakes, and they're causing scenes. These are just small examples of things I've seen in practice. And I know my colleagues in the community will also have their own stories about that. So, but yeah, these are some common things seen.
Okay. And I appreciate that feedback, because I think one thing is like, I think when we see like a relative, loved one, family, friend, have an episode, right, we tend to like want to dive into action when it's like severe. But it sounds like, they may be in an acute or chronic status where, okay, we're seeing things, they're managing day to day, but we're still seeing them have these episodes or experiences. What would you say to the family members that witness this, that may see a concern? What's the best way to approach this whole situation?
Yeah, depending on the severity of what's going on, definitely see if you could help your loved one get an appointment with a mental health provider, like a psychiatrist or a psychiatric nurse practitioner or a physician assistant. These are prescribers of the medication, somebody that will be able to manage them. And that person will be able to evaluate and say, okay, they could do normal level of care, which is outpatient. They come to our appointments, we schedule an appointment. I'm going to see them at the time we both agree upon, and time and date. Then the next level would be where this person is not functioning well occupationally, socially, academically, and their personal life is falling apart, and to the point where they're doing things that are considered bizarre, like they're walking to the street, they're disrupting the community, and that's where sometimes the police get involved because people could be disrupting businesses because this person is out of touch of reality. And so that's where the police come in, and that's where we see that. And that's where we also sometimes see high levels of homelessness because it gets to the point where it's burdensome, and some issues may go on in the family where they cannot continue to support their loved one. And a lot of times you may see people homeless because they've been kicked out of the house, or they can't maintain a job to pay their bills, to pay their housing. So this disorder is very debilitating.
Definitely, because I was going to say that too. I'm going to just tell you, Doc, realistically, it's hard when you have an adult, right, that you're trying to support. Like you see a concern and they're just so resistant, right? And I know a lot of times it's fear-based, right? They like, I'm okay. It might be fear-based. It might be denial. It might be both, right? And so I think that could be mentally and emotionally taxing on family. And so I feel like that's why it's so sensitive to kind of know how to approach this person, right? Like, hey, I've been concerned about you. You know, have you been feeling okay? What's going on? You could talk to me and kind of open it up. For me, I would even say like asking that person when was the last time they've been to the doctor. You know, have they, have you mentioned to your doctor you've been feeling tired or whatever? Not necessarily focusing on the erratic or impulsive behavior, but make it centered around something else, because it's very touchy, it's very sensitive when you're dealing with someone who has these, I would say, very severe and complex mental health illnesses, because it's just different. Like, I think the way they think, right? Like you said, their reality is very skewed, and so it can be challenging.
Yeah, definitely.
So what? So let's talk about the. I wouldn't even say the triggers, but what makes up these illnesses? I know we're talking about the psychosis, schizophrenic, bipolar. Do they all have a relation? OCD, as far as like.
Yeah. So.
Okay.
Yeah, so this is a good question, and a lot of times it could be genetic, like in your family bloodline. It could also be environmental. It could such as a person having a traumatic head injury, or as a child, or concussion, or whatever, some type of thing that altered their brain. Or when I say genetic, like it could be from your mom's side of the family, your dad's side of the family. And so a lot of times when I'm talking to patients, I really actually dig in into family history. And I'm always asking questions about that, because that's going to give me clues to see how I can help this person out. But sadly, and I've seen this across the board, and it's not like I've seen this in white families, black families, Asian, Hispanic families, is that the secrecy, where that secrecy in families really does hurt, because they're not sharing information. And a lot of times people don't really know where things are. And everybody says, yeah, I had that one uncle, or grandparent, they said that my grandpa's brother was always going to the hospital, but we didn't know what was going on. And so these are now become stories and tales in the family. And but really it was just the mental health not being treated. And so that's where a good portion of this does come from, through genetic. And it's not coming out of nowhere, because it's just back when you look back in the 60s and 30s, or even how far you want to go back, these relatives were exhibiting these behaviors, but it wasn't treated. A lot of them had to self-medicate with alcohol, where they say, "Oh yeah, such and such was an alcoholic," or they did a lot of drugs because. And I sympathize with people from the past because there were not treatments out there, so they had to take matters into their own hands.
Yeah, that's a good way. And also, too, I believe, especially in the Black community, they did a lot of prayer over it. And, I'm a believer in prayer, but you have to recognize when medical attention needs to be administered, right? Like you need to seek that because, that could, not help the situation either, the person who has this mental health challenge. So, yeah, it was definitely tough for them. I know they did the best that they could with what they had. And that's why I have these conversations, right, to inform the population that mental health professionals are here to support us. We need mental health. We have been neglecting that for so many years because, we didn't have access. And again, there was this stigma around it. And so now it's out here. It's a resource, take full advantage of it, people, because it's so necessary. And mental health impacts your physical health, right? So your emotional wellness. So it's just a component, right, of something bigger. So
yeah, everything you're saying is spot on. And the thing about the prayer part, this is what I tell patients, about people in the faith community. I know a lot of people say, yeah, pray and you can pray it away, but a lot of times I'd say is change your prayer point to please, let God find us the right person to help our family member out, and have your hands on that provider so they can make the right judgment, the right decision making. And I think that's a good way to change your prayer point. And that then plus that the loved one will be receptive to receiving treatment from this provider that, God has sent them. So
I like
those are the ways that, and that's the way I look at it I'm a person of faith.
Yeah.
And I also, I always allow my patient brings that to me and they're saying, hey, doctor, about this, and they open the door for me to come in. Then we talk about that and I incorporate it in our session so they could feel as more comfortable that, that I'm including their mind, body, and spirit. Like you said, it's physical, but I also see it's also spiritual. But I, for one, always want to make sure my patient is the one that introduces that topic and I come in and not me putting my views on them.
Right. I love it. I so love that. Yeah, that's a really great perspective, right? To kind of give, to be like, okay, yeah, let me include that in my prayer, right? That the right mental health professional can come in and treat my loved one or myself for that matter. So yeah, that's a really good approach.
Exactly.
Yeah, I love it. So, okay, so I know we talked about the genetic piece. So is there also a trauma piece, sexual trauma, physical trauma, mental, emotional trauma, that it can play a part with the genetic? Or can it just be a whole separate, like you had like a very awful childhood due to sexual trauma? Could it develop into a severe case of bipolar or schizophrenic? Or is it like a combination? I'm just trying to get a better understanding.
Yeah. So you make a good point, and I wanted to emphasize, our brains are always adapting and changing. And so a lot of times when people have these trauma or adverse childhood experiences, events, what happens is your brain is starting to change. And so a lot of times the youth or young children, they either is sexual abuse, emotional abuse, physical abuse, or they witness domestic abuse, or in their neighborhoods where they witness gang violence, all these scary things that, going on. Their brain is developing and then their brain starts taking roots another way. It's kind of like, imagine when we plant a seed in the soil, right? Mm-hmm. The roots are going to go a different way, and depends how you water it. It could also depend on that soil. So that's also the environment. And so you have sometimes good seeds and bad soil, or whatever, analogy you want to put it,
Mm-hmm.
And what happens, it takes root, and it probably doesn't grow well. And that's all what's going on in the brain. And so that's where the person may have depression. It may lead to, how the brain is forming for this person. And if there was a genetic history of like schizophrenia, bipolar disorder, these traumas might enhance that and make it come sooner than later. And so these are all factors coming in, and that's where a person may have mood problems, like their mood is unstable,
Mm-hmm.
their sleep patterns are broken, they're always startled, they're always on edge, they're always on guard because they're scared of that monster. Because think about it, when the fight or flight response for everybody. If me and you saw a lion, we're gonna run, or if we're swimming in the ocean and a shark was there, we're gonna try to swim as fast as we can to get on the boat, and that's a natural stress response. Imagine that you are a child or a person, and you go home in your environment or even school, you're bullied all the time, or you're beaten all the time, or the monster is living in your house, or it comes to your house and molesting you. And so and that's where that stress level rises. Your cortisol is always going up, and this is not natural. It's supposed to be, you have a stress response and it calms down and it's not there. But when it's there all the time, your brain is now overactive. It is always on guard, and your brain is now forming to protect you from these situations, but then now manifest in your symptoms and your behaviors.
Wow, that is something. And you know what? I want to stay here too, because I think too, people don't realize, and I try to put emphasis on that, like, stress is normal. Stress is a part of life, right? And I think stress can be healthy in some ways, but stress is unhealthy when it's prolonged, right? It sounds like that our bodies can handle stress, but it can't handle stress for days, for weeks, for months, right? Like moments.
Yes.
Is that correct?
Yes, it's unhealthy. It's not natural.
Right, for it to be extended that long. So, I just want to put that, that out there. People, like stress. We have a healthy, we can have a healthy amount of stress, but if it's prolonged, then that's when it becomes, okay, we need to kind of correct this and see what's going on. So I'm glad you mentioned that.
You're spot on, Shay. Yeah, you're spot on with that.
Thank you. So, okay, because, I want to learn too. So, okay, I know I, had highlighted some of the diagnosis, but I kind of want you to kind of break it down. So, like, I know bipolar is more of like a mood disorder, right? Okay. And so if we're looking at PTSD, what type of disorder is that? Is that a mood also?
So that was more, they had that more on the anxiety disorder, but now it's a trauma and stressor related disorder. So that's where PTSD is classified as.
Okay.
And some of the things that the public knew through movies, they were like, okay, the people that went to war and they have PTSD, which is common, like the stuff they saw, it's very traumatizing. But also, everybody can have their own trauma from directly being involved or witnessing or finding something about a family member.
Yes.
So trauma can impact a person in different ways, and that's where things are classified under that trauma and stressor-related disorder family,
I'm so glad you mentioned that because, that's the first thing that come to mind. I wasn't in war. It's like, okay, I get that, but no. PTSD, you can have that even in an environment you grew up in, right? If it was hostile,
Yes, exactly.
Yeah. So,
or even a car accident.
Yes.
So let's say somebody was in a car accident. They have that's a very traumatic experience. Or somebody having, a family member murdered, or a person in a breakup, a relationship breakup, where that was traumatic. They found out their spouse cheated on them. Now they're in a traumatic stressor related disorder, or they were laid off and then everybody handles things differently. But let's say this person that lost their job or lost their business, and they were so tied to it, and the stuff that came from losing that job was they lost their money, they can't pay for their bills, they might get homeless, they have to downsize, they can't go to their medical appointments, so their health deteriorates. So all of these things accumulating is very traumatic for a person. So that's why when people come to me, telling about the story, I take it for what it is and hear their story, because that's their story. And we can't look at somebody and say, oh, just because you weren't in the war or you weren't sexually assaulted, your trauma is not to be heard or seen. Everybody has their own unique trauma, and that's what they're dealing with the symptoms like nightmares, flashbacks, avoiding like reminders of their trauma and stressors, or being always on edge, being moody or having problems with their sleep. It's just like there's so much compounded there that it. Yeah.
Yeah, I'm so glad you mentioned that. Okay, so now schizophrenic, that's more of a genetic or no?
It could be genetic, environmental, and even substance induced.
Okay.
Or it could come from an infection. So there's so many ways we're trying to figure out where does it come from in the person. So a lot of times it's coming from the brain, so we know that. And so a lot of times we try to give them medications to reduce like the dopamine, so that way they're not having the symptoms of being paranoid, hallucinating. Those are the common things that we see, or the most of the public sees is, oh yeah, that person is paranoid and they're schizophrenic, or that person is hearing voices or seeing things and they're schizophrenic. But a lot of times too, people who have schizophrenia, you notice that their facial affect, where they're looking at kind of like flat, no emotion.
Yeah.
They have low motivation to get things done. They isolate, withdraw,
Oh
so this is what we call like negative symptoms,
So that would
and
be
what we call positive symptoms. Yeah.
Okay, I'm sorry.
And what we call positive symptoms. Oh, no worries.
Yeah.
No worries.
I'm just trying to get all this in. Okay, so that would be more. What type of disorder is that? Cognitive? I'm just trying to put it in a bucket.
So it's schizophrenia, because schizophrenia is more of like a thought disorder. That's the way we look at it.
Okay.
And a person can have, cognitive declines based off of how severe their disorder is. They have problems with what we call disorganized thinking, because when they're talking, things are not just going in a straight path. It's like jumping around.
Oh my God. Yes. Okay, I'm sorry.
Yeah, no worries. And their speech, and when they're talking, you're like, huh? When you're listening to them, you're like, what is he trying to say? What is she trying to say? Yeah. But it's disorganized. Yeah. So
disorganized.
That's, so it's a thinking disorder, and that's why when I work with my patients, because I feel for them, because you're not in control of your thoughts. Right. You're always trying to figure out is something real or not real. And it's sad, because, I really sensed it. So one time I think it was during the pandemic, and I was in my house, and there was a patient that was having hallucinations, and for some reason the piano, somebody was playing the piano, and they thought that they were like, am I hearing it? Something like, and they're like, no, I was like, that's real. That's somebody playing the piano. And I feel sad, because that's, the person trying to figure out what's real and not real. So that's why I want people to sympathize, and it's not, because when people see somebody in schizophrenia talking to themselves or paranoid, they start laughing or not, and that's where the stigma is. That's why I'm so happy that you're out here, educating people, bringing in experts to talk about what's out there, because I want people to look at it from a standpoint. This is a human being that is struggling with symptoms, and like, when you can't tell what something is real, like we may say, laugh at it, say, yeah, man, it's not real. But for them, that's their life.
Yep. And I heard someone say, I watched, it was a program I was watching, and the young lady, she was taking care of her dad who was suffering from dementia, and she was just so frustrated. And the caretaker came in and said, "You have to meet him where he is." And I just thought that was so powerful, right? Like,
Mm-hmm.
meeting them where they are. If they say they seeing that, you know what? You probably are, but I think you're safe. Let's get you to a safe area. Kind of, you know what I'm saying? Meeting them where they are, keeping them calm, or just following along and be like, "Oh, okay, so what was that again?" You know, and not like you said, like, "What are you talking about?" Like, you know, because that kind of gets them in this
Yeah.
state where they feel like, "Oh my God," like they feel unsafe. That's what the body is telling them, right? And so then they
Mm-hmm.
they react even stronger, right?
Yep.
Oh my God. So yeah, this is good. Okay. So psychosis, what type of disorder is that?
So that's where it will be also classified with the schizophrenic disorders, psychotic disorders. They're all in the same family,
Okay.
where someone's having bizarre behavior, hallucinations, paranoia. So that's all in the same family. So
Okay.
it's not far off. So I just want to make that very simple to
Yeah.
the to your listeners and your audience that it's under that same family and umbrella. So, like,
Okay.
so for example, when we say, "Oh yeah, that person's psychotic," and a lot of times, like us practitioners, or we see this a lot in the emergency rooms, where somebody will bring in their friend or their loved one, and they're saying, "Yeah, he was normal, such." Then we find out, oh yeah, that he smoked something or he consumed some type of substance, and all of a sudden, this person is psychotic. So they're very paranoid. They're doing things that is not their usual self. Their reality is impaired. The way they see reality is impaired.
Mm-hmm.
And so that could be what we call substance-induced psychotic disorder. And also, too, a person does not necessarily have to be using like a drug. It could be a regular prescription medication they took, and they may have taken a little bit too much of it, or the dose quantity that they took caused them to be psychotic. So that's what we say substance abuse. It could be a prescription medication or over-the-counter medicine or something from the streets, you know.
Okay, so I got a question. Okay, so I
Mm-hmm.
have seen individuals that they call it and I don't want to be offensive, but I saw it on Google. It said like a religious delusion where like they could just be reciting scriptures and then they'll just have a whole conversation talking about the Bible and what God told them. Like that's I've seen that from individuals who have this sort of diagnosis. Have you heard of
Mm-hmm.
that or seen that in your clients?
Yeah, that could be a person that kind of a symptom of, schizophrenia or one of the psychotic disorders. That could be somebody even who is like bipolar, and they may think they have these elevated sense of self that, yeah, I'm a prophet on earth, or, I mean, I'm not saying they're not prophets, but just saying that something that
Right.
they weren't before. Yeah,
Yeah.
and they're saying I'm this and that, and they start quoting everything, and they're like, and they're now saying, yeah, you are sinners, sinners. They're like, it's just they take their religious levels to the next level, and
Yeah.
those are some religious preoccupations, religious delusions. So there's not a specific, um, like we're gonna say, oh yeah, your religious disorder, religious disorder,
No, right.
but
But
it's more like it's a symptom of,
it kind of, for
like a
me,
psychotic.
yeah,
Yeah.
I'm sorry. It kind of, for me, it mimics a manic behavior. Like,
Mm-hmm.
because they will go
Exactly.
on and on and on. So, it's like, okay, yeah, something's going on here. You know what I'm saying? So, it's no
Yeah.
disrespect to believers who are in the word, no disrespect to that. But you have to know when it's like, okay, this is unusual, right? Versus,
Yes. Exactly.
that. So, that's why I wanted to make that statement. Okay. And then the
Mm-hmm.
last one, OCD.
Oh
So,
yeah,
what's
that's a OCD. Yeah, it's definitely. Yeah, go ahead. I love that disorder. But yeah, I want to definitely.
Yes, I
Um,
want to talk
hear
about this because this disorder isn't talked about. So, what type of disorder would that be classified as?
it's his own disorder, and so here's the thing with OCD that it's a lot of times the people with OCD, and I've talked with this with my patients. Like the reason why you said that most people don't worry about the OCD people because they're able to still kind of function in some sort of way of doing their normal tasks and activity, go to work because they're not just making big disruptions like you'll see. Like they're not the ones getting hospitalized because they're not the ones like saying all the time, I'm trying to kill myself, or they're not in the streets disrupting things, but they're disrupting things for themselves. So that's where their impairments come from, where it may take them an hour to get to work because they have to walk through their door like an X amount of times, or they have to go back and check to make sure the stove is off, the door is locked, the garage is down, and they keep doing this loop for like an hour. And so a lot of times it is that they're the ones punishing themselves. And the best way I would say it is a lot of people with OCD have what we call intrusive thoughts, images, or urges. So that's where the obsessions come from. And a lot of times I talk with my patients, they have this, I say, an internal bully. Imagine, and that's the way, when I say that to them, they connect immediately. Like, yeah, I feel like I have this internal bully in my thoughts where it's saying, you can't do this or you can't do that. If you do this, this is going to happen to this person. Like, if you sneeze, then everybody's going to drop dead or something like that. Or that's just one random example. But it's just their thoughts are torturing them. And it's painful. And that's why when I have OCD patients come in, like you see it in their eyes, and their loved ones are going to be the ones that are going to tell you everything because they're also sometimes frustrated with the stuff that their obsessions and their compulsions. And compulsions are repetitive, like physical or mental acts to kind of repel those obsessions. So let's say, for example, I have an obsession that, let's say that if I sneeze or something, like all these airplanes are falling down. This is just some random thought, okay? And it's very intrusive because you don't want to see somebody get hurt, and then you're compelled to do an action where you might have a mental act where you're counting to 200. You have to count to 200 for the thing not to happen, or a physical act where if I tie my shoes like a certain pattern, those planes will not fall down or something like that. And so imagine that consuming you and being part of your life, these rituals, these acts, and it's very painful. And then talking about going back to the religious part, I do have patients that have these religious obsessions, and it's painful for them because they could sometimes feel like they're a sinner for doing something. Like if they are like married and they had to look at another person that's not their spouse, they start punishing themselves, and these are thoughts like, "Oh, I'm going to hell. I'm going to," and they have all these thoughts. I see it a lot within the religious community. People in the faith community, and they're telling me their personal thoughts, and they're like, you wouldn't even know it because they go to church, they do their good job, but when they're telling you person to person, they're like, "Doc, this is going on with me," and sometimes I feel like, is God going to punish me? Am I going to hell because I did this? And you have to talk to them about they know what's real and not, but it's just their thoughts are so intrusive to the point it is, damaging, shameful.
It sounds like it's tormenting them,
And that's why I call it the internal bully. And so that's why, for me, why we created Genesis TMS and Wellness, the practice, my wife and I, because in Genesis TMS and Wellness, one of the things is we could treat OCD with no medication. Okay. And now I have a new another treatment source to help my patients out who struggle with OCD, and that's something I'm very proud of. And that's where my business partnered with NeuroStar, who is a medical device company that is cutting edge, and they're like, I believe in their vision, they believe in my vision of serving those people that struggle with OCD and major depressive disorder. And that's what transcranial magnetic stimulation does. It's another source of treatment for OCD.
I love that. Congratulations. I got to give you applause on that. Give you applause
Thank
on
you.
that one.
Thank you.
That's awesome. No, I'm serious. Like, to even think of a method like that without medicating, like prescribing something, that's awesome. I am so here for that. Yes.
Yeah, and because OCD could be treated by like medication and therapy as well. So
Yeah.
there's different ways to
Do
to treat
that.
it.
Yeah, because I think
Mhm.
for the most part, people of color, black folks, they don't want to be on no medication, and I think that's part of the
Mhm.
reason why they're hesitant to go see a psychiatrist. It's like, I don't want to be on medication. And it's like, look, you have to think about it as you're taking care of yourself, right? Your mental health is just as
Mhm.
important as your physical health. And I honestly feel like if you're going to take a pill for cholesterol and high blood pressure, come on now. If you need a pill to kind of balance out those moods or those impulsive behaviors or those manic episodes, it's all for your benefit. And so it's all about reframing. It's all about taking care of yourself in a whole nother way that, our ancestors didn't. And I feel like, too, for me, anyways, it's part of how I honor them, taking care of myself in that way where they couldn't, you know? So, yes.
Yeah. Mhm.
No, go ahead. It is good that people prioritize their mental health. So, I enjoyed this conversation. Like I said, I have been waiting forever to get a psychiatrist on. I know you guys are booked to max capacity. Your time is
Oh God, yeah.
valuable. And your time is valuable. So I want you to know I appreciate that. So before we conclude, is there any lasting thoughts you want to leave for the people listening?
Yeah. Two things. First, I would say I want to give a shout out to all the caregivers out there who and loved ones who are supporting their family members, friends, coworkers. Your support is phenomenal, and it brings joy to my heart when I see patients come with their family members, and their family members are under session, because the more people that are involved for support, the better, hopefully, the better outcome. So, and I always come with the collaborative view. Okay, you guys know your life more than I would. I'm more of the the psychiatric consultant, recommender. I'm the physician on the team. Then you're the one living your life, and I try to customize what you're telling me with my medical knowledge. And so I try to make sure I incorporate everybody. I think that's a good thing, having the family support and then their therapist there. Everybody that's there to see you win is good for us to collaborate. And so that's important. But shout out to the caregivers, because they have a heavy load, and they're the ones too that need support. And so that's why I will say, if any way that you could see somebody as a caregiver, help them out. Like, say, hey, can I help you run an errand? Or do you need me to cook something to take off your plate? Those people, kudos to them.
Yes.
And then also, I would say to the audience, I loved what you said about if this was like diabetes or high blood pressure or cholesterol, you'll treat it. Take the same thing with your mental health. It's hard to be vulnerable, but help is there. And you are a strong person if you ask for help. And you're not weak. And if somebody's calling you or clowning you and saying you're weak because you're doing that, you don't need them in your life, and they're not for you. Okay? Yeah. So that's what I want to say. And then lastly, I love sharing my knowledge of mental health and wellness. And if you like more topics of this, you could please find me on social media. I would love for you to follow and see what I have and share too, because I feel like the more information there is, the better we could normalize mental health. And you can find me at Dr. Olele, which is DoctorOlele on Instagram, Twitter, TikTok, and you'll see my educational videos there. And then my practice handles are at GPS Mindset, and that's where you can find us, our YouTube channel, Twitter, IG. And so I'm there, and yeah, definitely I've met stuff you could share, and let's break down the stigma.
Yes, we are breaking it down, and I'm going to leave all your information in the show notes so they can just tap the link right there and go straight to your page. But I also wanted to piggyback too on family who are even attempting to support a relative, a friend with a mental health illness. Please, please, please do not fault yourself. Do not guilt yourself if that person isn't willing to get the help. It's hard. It's hard to support an adult who might be fearful to even admit that they need help or to see a mental health professional. But I want to say to you guys, just do what you can in your capacity, right? We can't force people to get help, right? We can only, be there when they're ready to receive it. And so I wanted to put that out there as well. Well, thank you so much, Dr. Olele. I really do appreciate it. I want to give you a round of applause again. For your commendable work. I appreciate your efforts every day. You're doing an amazing job, as well as all the other mental health professionals, especially in the Black community, because we are breaking the stigma. We are normalizing the conversation. So thank you, thank you, thank you.
No problem.
Yeah.
No problem.
And thank you guys for joining me. Until next time.